Roula Kotsifaki, welcome to the Pacey Performance Podcast. It's a pleasure to have you.
So nice to be with you. Thank you for the invite.
My pleasure. How did I do with your name? Any good?
Perfect.
Okay, perfect. It's a good sign of things to come, so I'm happy. So, Roula, if anyone doesn't know who you are, firstly they should do. Would you mind just giving us a bit of a background to you before we kick off?
Yes, absolutely. So I'm a physio. My bachelor was a physio. I worked as a physio. I had my own clinic back in Greece. And then I moved in Doha. I work in Aspetar for the last 10 years. And the last 8 years, I work in the assessment lab. This is where all the magic happens, if I may say. And we're doing only testing for our athletes. I finished my master's in University of Dundee. And then I moved on with my PhD, which was in Leuven University, and there was some musculoskeletal modeling involved. The main question I had was what was the status of our athletes after passing the discharge criteria in terms of biomechanics. So we think they're ready. Are they really ready? And I feel like this is where it started everything on testing, which tests, and moving on from there. At the moment, I'm the head of the assessment lab, and our goal is to expand the way we work and this model in other pathologies, not only in the ACL. And this is the current status now.
Perfect. And I probably should have mentioned this before, but you're coming to the Sportsmith Rehab Conference, which is on the 12th and 13th. So thank you for saying yes to coming to the conference in Manchester. So really excited to actually get you speaking and obviously meet you in person, because I never get to meet people in person. This is the selfish thing about these conferences. I get to actually meet people like yourself who I speak to on podcasts and things and get to meet you. So would you give us a bit of a teaser of what you're going to talk about in Manchester?
I'm very happy to be with you and all the other speakers. Everyone is unique, and I think it will be amazing. Each part will contribute of how we can rehab our athletes. My part is about ACL and testing. So basic idea is which tests, which metrics, which are better or which not to use, or maybe waste of time, or why this metric and not the other metric, I guess. Most importantly, I think I will try to explain the why. What is the reason we choose this test over this test? And why all these tests? Maybe we are overdoing with all the testing. Where the end is, and use the technology to help us in the decision making. Is it enough? Maybe we need more, maybe we need less, maybe we overdo it. I will try to cover all these points in our presentation from a clinical point of view. It's biomechanics, it's numbers and technology, but the clinician wants this to be easy for them to understand. And that's my goal. We want to make it easy for everyone to understand the why.
Perfect. Excited for it. Really excited for it. So we're going to chat about a little bit about some of them things now. Obviously, you'll go into more detail when you're presenting in Manchester, but kicking off the podcast, what tests should we be focusing on during return to play from an ACL? Big question.
How much time do we have? Right. At return to play, right?
Correct.
Yes. We'll try to measure everything in terms of, it's not only strength apparently. Absolutely important, but it's not only strength. It's not the only thing that makes our athlete back to normal again. So the whole idea is how you construct a testing protocol is what are the competencies that we see at the end. And this is where we use the literature. So we've seen, we have problems in running 2 years later. We have problems in strength 2 years after ACL reconstruction. We have problems in jumps, horizontal, vertical, whatever that is, in acceleration, deceleration. We need to find a way, of course, to rehab these specifics, but also to test and make sure that they're back to normal. Now, what is normal? We can discuss this later, but that's the basic idea of how you construct a return to sport protocol. And then we need to define what is the right metric for what we want to test. So if it's strength test, quad strength, what is the best test that we can use and get the results we want? It should be sensitive. It should be able to detect differences from the other limb. It should be able to show me the improvement over time during rehabilitation, and should be demanding enough at the end to expose everything. So this is about strength. You define your test and then you go for other competencies, acceleration, deceleration, change of direction. How can I measure these things? One of the things that always come out is that you're talking about vertical jumps, for example, but this is a movement that they will never do in any sport in this way. You are giving the instructions, and the way you are testing, we are always asking them to keep their hands on hips and do a specific movement with specific instructions. They will never use it in their sport. I totally agree. This is not the reason we're doing this. We need to standardize the tests so we can compare people between them and the same athletes with the previous test. And we choose the test that will be sensitive enough and will expose any problems remaining. And this is how we choose a test. That's the philosophy. And then we go from there, and this is how the Hope for Distance started. As you know, it was strength, and some people were using some Hope for Distance test. And before that, and we are lucky if they were testing strength or Hope for Distance. Most people, they were just using time. So it's 9 months, okay, ready. We are happy that we had at least the strength test and the Hope for Distance test. My objection was that what literature says, what we found in our studies is that it's not enough. It's not the test that will expose the remaining problems, if any, at the time to return to sport.
So what is Hop for Distance? How far is it getting to that point of understanding what we need? Is it getting a little bit of the way? Is it getting none of the way? Mm-hmm. Is it useful at all?
Yes, nice one. It's one test like many other tests that we can use during rehab, especially if you have no equipment, right? It does not differ from a double leg squat that we use in the beginning. So in the beginning, this is as far as they can do. We use the double leg squat just to see the asymmetries in the loading between left and right? Hope for Distance, of course, it's more demanding, but it's somewhere during rehab that you can see differences in Hope Distance. Let me put it another way. If they achieve similar distance, or the other way around, if they don't have similar distance, same distance, definitely they're not ready. If they have similar distance, you don't know. So they might have same distance, but they're somewhere in the middle of rehabilitation because they find ways to compensate. And also because the distance doesn't actually measure the knee walk, how much the knee walk during this task. It's mostly about the hip and the ankle. So why are we using this test to evaluate any knee pathology? If we measure only the distance. There are some exceptions, and we can discuss about these other pathologies. But right now, this is what happens with a hop for distance. So for a discharge test, I don't think it gives us any information if our athlete is ready or not. Just measuring the distance. Hop test is my favorite test, still is. When I have the lab and I can see how they work in the landing, where it's the most demanding test compared with the other test at least we have, unless there's any other test that I'm not aware of. So the test itself is amazing. It depends which metric you are using, and hop distance is not enough.
So if we're comparing against the uninjured leg, what if the uninjured leg is terrible as well? Okay, if we could, sorry, distance.
Yes.
If I'm underprepared generally, and I have ruptured my ACL, my unruptured leg is rubbish too.
Absolutely. Maybe.
So okay, maybe. Okay. So if we're looking at the injured leg and thinking, okay, they're similar, but similarly rubbish, that can't be great either.
Yes, I understand your point on this. It's a performance metric, so you compare it with normative data, I guess, to say that it's not good, right? Okay, let's say both are bad. So what? What insight you will take if you just measure the distance, if you are not evaluating how your knee joint works? That's the main point. Let's start from there. The contribution of the knee during the hop distance in the propulsion phase, it's only 13% based on the research and control group, right? Which means that how far you go is determined like 90% from the hip and the ankle. So maybe it's a better test for the hip and the ankle than the knee. Landing is something different if we want to go there. About landing, we need to know what is the variability in the test. Specifically for landing, what I've seen in the results and the research, and it's all there, and there is a nice figure in one of the papers, but it's not obvious. There is a huge variability in the landing component, which means that every single one has a different landing way, right? The only comparator you have is the other leg. Good or bad, this is the only comparator. So for some metrics, the only valid comparator you have is the other leg. So let's not put LSI totally on the side. It depends on the metric and the test. I will give you an example. Average is 65% the contribution of the knee during landing. So this is a task that is mostly about the knee. If the knee cannot do the test, they cannot even start the hop distance. There are people that they have 70% contribution, there are people that have 30%. But the other leg also works the same. This is who they are. So, and this is where the quote I'm always using, every athlete is unique, applies for this metric specifically, not for all metrics. And we have a similar pattern during the landing of vertical jumps. So, stiff landing, soft landing, yes, fine. We can use this term, but don't forget that everyone is different and has their own pattern. I'm not sure if we want to change how everyone is working already and which one is the best. So for the landing, the only comparator we are using at least is the other leg. Good or bad? Positive, negative, we cannot have always everything. But the normative data, I don't think it's the best one for this test.
So you said it was your favourite test if you're doing it in the lab. So what technology are you utilising to ensure that that's your favourite versus no tech at all?
We're using force plates, but we need 3D force plates, and we're using our biomechanical cameras, 3D cameras. And the reason for this is that we cannot see this power metric. We are using the power to see what is the contribution of each joint. So GRF is not enough. Most of the times they have the same GRF, so just measuring a vertical component of the GRF is not enough. So using just a uniaxial force plate will not give you insight of how they're compensating or if they're using their hip more. So this is what we're looking in the hop for distance for landing, if they actually use their knee or they compensate from the hip or the ankle. Many times they ask me, what if I have a photo, I make a video, and then I can measure the knee joint angle, and then I can figure out something there. Unfortunately, we don't have a proxy for this because it's not the joint angle that creates the big difference. It's the moments. And I will translate this is how they position their body, the whole body, during the landing to do this task. And the knee joint angle will not give you the answer. They might have 90 degrees, and you can measure this with a camera or the phone in both legs, and the moments are totally different just because the body positioning is different, just to say it in a simple word. This is what I want to measure because it's the most demanding task for the knee, and I want to see how they're behaving during this task. If they can absorb, everything is perfect with their knee. Still, it's one axis. It's just horizontal. And it's not what they are doing in sports. That's why we also have the change of direction, which is the only test, at least in our protocol, that it's not in one axis. So we have the vertical axis. We have the horizontal, but we have the change of direction where you use how they behave also in all three dimensions. And this is where we challenge the knee not only horizontally or vertically, but also in all three dimensions. So these two tests we need the lab, we need to do the full catastrophe. And Enda in his papers found that unfortunately again, we don't have an easy proxy to see how they're doing during the change of direction task. It's not the time, the contact time that we can measure, it's not the speed, it's not any of this, it's the biomechanics. That's why we need to use the lab for these two tests. Maybe in the future, and we're working on this, and other groups I know they're working on this. I hope we find something because they are both really important tests. Maybe it's too difficult in a club to have a biomechanical lab. I don't know if they can go that far. But this is where our proposal was, okay, not many, and it's not easy to have a biomechanical lab. What is the other thing that you can use as a proxy of the readiness of our athletes? And that was the vertical jumps. And this is what we propose. You don't have a lab to measure horizontal test. You don't have a lab to measure change of direction. Use at least easy technology to measure your vertical jumps. And you will have so much information that you are almost 90% in your rehabilitation once they pass the vertical jump tests. So we never said nothing works. We came back with a proposal. Don't measure horizontal hop in just measuring distance, but you can use your height, jump height in a vertical test, you can use your RSI and other metrics, and even more if you have force plates, uniaxial force plates, and you can get a really good insight of what is the status of the athlete.
So if there's no technology whatsoever, what would you recommend from the vertical jump?
Single leg drop jump.
Okay.
Period.
Perfect. Perfect. Single leg drop jump. So for those with no cash, no budget, no technology, single leg drop jump.
Phone. Use your phone.
Perfect.
Use jump height and even better the RSI. Start with RSI, which is jump height over time, and then go into the details and see which one is not there yet. Is it the jump height? Is it the contact time? And work on the specific. It's a very difficult test after an ACL injury to get a single leg drop jump, the RSI back. A very difficult one. If you achieve that, this is what I'm always saying, you are almost 90% in your rehabilitation. So there are no excuses.
So if you do have technology and you're lucky enough to have a pair of force plates, what metrics would you recommend? And what test and what metrics would you recommend?
Are we still in the end phase of rehabilitation? So it's the discharge phase. Because every test will give you a slight different information. I definitely would like to have a bilateral jump, and I definitely would like to have a unilateral jump. Right now we are using all four, a single and a double counter movement jump, a single and a double drop jump. And we get different things for each test. We want the counter movement jump or the drop jump to see the difference in the concentric and the eccentric phase and the landing, but we need to be careful about this metric and how we interpret the results. But we want to see, using the force plates, where the problem still is. Is it the concentric? Is it the eccentric? And then the physio will work on the specifics. I need to improve this, or both, or none, or I'm good. The concentric and the eccentric phase, the eccentric deceleration phase, they're both phases of the jump test that athletes cannot cheat. No way. And athletes at the end of rehabilitation, especially if you have repeated tests like we do, they are grandmasters in cheating. They know exactly what to do. For these phases, you don't know they don't know how to cheat if the knee cannot do the task. They can cheat in landing, and that's why we need to interpret the results accordingly. So I pretty much trust this test and these metrics to get an idea of where I need to work.
Is there anything? My next question was landing. Why do we need to be careful? So the cheating aspect, which is interesting. The grandmasters of cheating. I like that. I really like that. So how are you identifying those that can manipulate things on a landing?
This is easy. This is very easy. They are doing their discharge test, and they land always on the involved side because they think that this is how they pass the test. But if they can't do that, I'm already very happy. Because in the beginning of rehabilitation, or the first test we do using vertical jumps, 3 months or 4.5 months, so their first test, most probably they cannot do that. They cannot land on the involved side more. They will unload the involved side and they will use more the involved side. And they cannot cheat because they don't have the capacity to do so. But as they progress, you see that they start landing using maybe one, maybe the other one, or both, or symmetrical, whatever it is. Once they can use their involved side during the landing phase, I'm already very happy. And then you use your normative data and see how non-injured athletes are behaved to get this insight. So non-injured athletes, they have the same pattern. You do a counter movement jump and you see during 4 trials, the first trial they use more the left, the second more the right, the third the left again, and this variability is more than 20%. And there is no injury, and this is normal, right? So we need to use this when we expect for our ACL population or injured athlete that we want something similar, right? So a 10% cut-off, I don't think it's fair, because uninjured athletes, they have more than this. The variability and how they shift left and right is more than this. So we need to be fair with our injured athletes and not expect something that we don't see in the uninjured population. And this is where we're more flexible of the symmetry or what we expect them at the end. I guess to summarize this part, it's again, if they can land on the involved side, I'm already happy, even if it's 20% or 30% or 25%, as soon as they can actually land on this, and they all do after all this training. So it's not my most sensitive metric in my discharge battery of tests.
So you mentioned normative data. Where can people get their hands on some normative data to help during this process?
Yeah, that's a good one. So the paper we published in June last year, so it's 1 year, last year about the performance metrics, we had exactly the same questions. Our friends involved, they're very nice, so they have like 500 metrics. We have 4 tests. If you add all of the metrics together, there are more than 500. And our question was, which ones? And why this and not this? And which are the useful metrics? And that's why we did this study. So we had like 500 control subjects, which means no injuries in the lower limb. And we had all the metrics that VALD had at the moment for all 4 tests. And everything is in the paper, in the supplementary file, where you can see the normative, let's call it normative data for football players. They were all football players. So we're still using this data and these metrics to see how the metrics we are using are behaving. This is how we chose the metrics that we have in our testing battery now. This is where I think, and forgive me if I'm wrong, I don't like rate of development metrics. And it's not me, it's the results. You can see the huge variability in the test, in the results, in those tests, in those 4 tests. Of course, there is a lot of influence of the instructions, of other parameters in the results. But if you want to measure rate of force development, I wouldn't use any of those tests that I said described earlier, counter jump and drop jumps. I would use quad jump only.
Okay. Perfect. I've got one more question for you on this, and it broadens the whole thing. How is this how is this information, how can this information that you've just taken us through there translate to other injuries? Can it translate to other injuries? Yes.
We're trying to have a protocol for angle testing, for example. Let's take the joint pathologies and keep it broad. Let's be honest, the research in ACL drives everything. I mean, I couldn't find something different or something more in research about the ankle injuries compared with what we already have from ACL. So most probably we'll go the other way around. We'll use our insight on the ACL injuries and try to implement other joints like the ankle or the hip joint. And we'll use the background and the reasoning. So we know that in vertical jumps, all three joints, hip, knee, and ankle, walk almost equally. So during a vertical jump, I don't know which of the joints will contribute to the good or the bad results. For knee, it's really sensitive. For the ankle, for example, I would use a drop jump more than a counter movement jump. And on this, let's explain this a little bit more why. Instructions matter. It all depends how you will instruct your test and what you are looking from a test. Let me give you an example. Single leg drop jump. Your instructions are as fast, as high as possible. This is what we are using for the knee joint. If you ask only for as high as you can, what people will do is bend their knee more to achieve maximum jump height, right? If you ask as fast as you can, most probably they will keep the knee straight, extend it, so they will use only the ankle joint to achieve this minimum contact time. So if I want to test the ankle, I would give these instructions. If I want to focus only in the knee joint, most probably I will ask for the jump height, but then it's the same information with a single leg counter movement jump. So depending on the joint and what you are looking for, you will change your instructions, probably your test, and then you get the results you want about the specific injury. What other injuries we can use our insight from ACL? Let's go for hop for distance. I feel like a patient with active patellar tendinopathy most probably will not even start the test if you ask him to do a hop for distance. The load in the landing it's huge, and it's not that he cannot start the test. He is afraid of how he will land, how he will use the brakes. So most probably you will find even difference in hop, the distance itself, but the reaction just because he knows what's going to happen in the landing, pain, and everything else. So if you know the why we're doing each test, then you can use it for other pathologies and test the specifics you are looking for.
I spoke to Phil Graham-Smith, who was out there in Doha up until not too long ago. I don't know, 2 months ago, maybe 3 months ago. And he mentioned a comment around getting good data from single leg jumps and how difficult that can sometimes be. Is there anything that you would recommend people, and you've mentioned the queuing there for various different reasons, is there anything that you would recommend for the single leg jumps specifically to ensure that people get good quality data?
Phil is right. It's tough. And if clinicians are working with injured population, it's even worse. And it's even worse in the beginning of exposure to jump. So the first time they will do the testing, although they did some kind of training, it's going to be bad in terms of eccentric deceleration speed and apprehension and all this stuff. So the question becomes, can I trust this test? Because you will get some data. Can you trust it? They will bend their knee during the flight phase. They will do everything. I think everything starts from instructions. You standardize your instructions. You make clear what you want to see. If the test is not enough up to the standards that you have set up, don't use the results to give you anything important.
Perfect.
Like every test, right?
Yep. So let's have a little chat around the battery of tests that we would do to clear someone to go back into, right at the end, back into full training. You've mentioned, obviously, we've gone through a lot of the jumping side of things and some of the change direction. Can you take us through the battery that you would take someone through, or you would recommend others take someone through post ACL?
Yes, absolutely. But all the tests we said is we are measuring the motor control, the mover quality, this aspect. We also have the strength aspect, and it's not only the quads, it's not only the hamstrings. We are testing hip muscles, abductors, adductors, external rotators. We are testing calf muscles with a symmetric test, and we take our info there is strength in all major low limb muscles is back. We are using as a comparator the other limb, always, it's there, but since we have repeated measures, we see how they're progressing, if they are improving. And what we most commonly see is that they improve during rehab in both limbs. Many times we had a problem at discharge that the uninvolved side is too strong and the involved limb cannot reach these values. Olivia Barbosa wrote a paper on this, the strength of the uninvolved. We hear a lot about don't use the other limb because it will drop down during rehab. This is what everyone expects. So the other limb is not a good comparator to have. We never saw that during rehabilitation. The uninvolved limb will drop right after surgery, and we expect this in both limbs, right? But 3 months after surgery, everything is back to normal on the uninvolved side, and then they keep on getting stronger, all our limb muscles, because we work on them. Of course, it will drop if you never touch the uninvolved leg, but I feel like by default this is never the case. So we shouldn't even discuss if the strength is deteriorating during rehab. Of course it will if you don't work on it. But if you have a plan and a rehabilitation protocol that involves both limbs, of course it will not drop. And if you have a weak player, you always want to make them stronger, right? At the same time, you need to take care about the symmetry. Because what if, and this is a real example, it's not out of my head, what if the uninvolved side, it's 4.6 times body weight for a recreational athlete? 4.6 body weight. And the involved side is 3.6. Is this good enough? Am I happy? He's very strong, right? But the asymmetry there is 30%, 40%. I cannot do the maths now, but are we happy with the result? We have 2 strong legs. If we don't look in the symmetry, are we okay to clear the patient? Or why yes, why not? Why not? I would expect that if he goes back playing football with his friends again, most probably he will use the uninvolved side too much, more than the issue, and he will come back with other injury. I would expect, I'm just guessing there, meniscus, cartilage, just because the difference in loading pattern. That's why we should monitor both limbs and use our logic, our clinical experience, our many other ways to compare if the results are valid or not and useful and enough to clear my athlete. So you have your other leg, you have your previous data, if they are improving, you don't want them to drop, and you have the normative. We use all of the three to make the decision, yes, we're in the right path, yes, this is what we want to achieve, we achieved, we tick the box, ready for the strength component, right? Where did we start it from?
I said the clearance for sport
yes.
testing battery. Yeah.
Yes, correct. So we said strength, right? all our limbs, and the philosophy of what's normal and what's normal, it's for the same for all our limb masses. It's the movement components. We use the vertical jumps from start to the end, and we use the metrics I described, and we use a hop for distance and a change of direction, and to have a full picture of the movement quality. Of course, clinical testing, flexion, extension, swelling, but I expect all these metrics are already solved at the end. Laxity measurements, you need to measure, and specifically for some sports, their cardiovascular endurance, right? If you want at least to work on the performance metrics. So we use a yo-yo right now for this, and we also would like, and we'll start soon, try to find a way to measure deceleration ability, and some other performance tasks. Let's see if we have something more that this test can add to the insight, if to say with better confidence that my athlete is pretty much ready to go back to the club.
Perfect. I have one thing to ask you, and it was one thing that came up in conversation pre-press and record, and it was time to return to sport. And I know that's something that you're and have been thinking a lot about. So and just using ACL, everyone knows it's 9 months. Of course, it's 9 months. What's your thoughts around this time to return to sport number that we put on things?
Yeah. Who knows that we are in the 9 months spot? So 9 months and 1 day, it's fine. 9 months, 1 hour before, it's not enough. I got asked a lot in the conferences, and especially by surgeons, give me a number. Give me a number. What is your number? Based on the craft, there is no number. If you ask my opinion, there is no number. They will get back when they are ready. We said about the readiness part, and we can discuss even more. Ready from the surgical component, ready from the rehab component. But a time frame, I feel it shouldn't be there. It shouldn't be there at all. Maybe it's too much what I'm saying now, but it's all about, if you have a successful surgery with the advancements in the surgical field, when they will return back, and if they return back to the pivoting sports, it's highly affected by the rehab and the quality of rehab that we did. If some athletes, they stop early, most probably they will never return to any pivoting sports like they did before. But if we talk in terms of re-injury, I feel that time is not the most important factor there. I don't think we can predict who will get injured or not, but we can say that there is no higher injury risk if you come back at 6 months, as long as you finished your rehabilitation, a comprehensive rehabilitation protocol, and that all of the competencies are back to normal. And if you did that at 6 months, good for you. You are ready to return to sport. Literature there already, UEFA studies says that they return back 7.5 months on average, and there was no difference in terms of ACL injuries. It was specific about ACL injuries, the study from De La Villa, the latest one. So for the professional athletes, maybe because they have all the resources available, and I guess Champions League and the UEFA studies teams, I only trust they did a really good rehab. So there was no differences in terms of injuries if they returned before 9 months, 7 months or 6 months or whenever they were ready. If you are not ready, maybe things are different. Not only for ACL, but for other ACL, for other knee injuries. We'll see.
Interesting. Leave us hanging there. No, that's great, Roula. Thank you very much. And I said I'd keep you to the hour on the clock, so I definitely will do. But really excited to get you over. Even more excited now hearing you speak. To get you over into Manchester in October. So hopefully there'll be plenty of people that can join us on the 12th and the 13th. But thank you again. Thank you for lining this up, and really appreciate having you. But just finally, if anyone wants to get into the detail of any of the papers that you've mentioned that you've done, and social media, where's the best place to contact you and get some of your work?
Social media, my mail is always, I answer to all my mails, and it's all in the papers, and all the papers, you can find them open access somewhere.
Perfect. ResearchGate? Is that a good place to go?
Yeah, absolutely.
Okay. Perfect. Well, Roula, thank you
so much for the invite. It was very nice.
My pleasure. Thank you for coming on. It's been a pleasure to speak to you for the last hour, and look forward to meeting you in person in 4 or 5 months.
Yeah, I feel it will be amazing.
Absolutely. Thank you, Roula. Speak soon.
Thank you.